We are still practicing mainly as we did 20, 30, or maybe even 40 years ago. And the state of the knowledge substantially changed at this time. So 30, 40 years ago, the only diagnostic tool that we had to identify patients with deep vein thrombosis with ultrasound. And it was the best available tool at that time. And then that was promoted, and that's what we used. Because today, the available data and the major guidelines all recommend the risk stratification as the first step. And that can be done by clinical, simple clinical structured questionnaire like Wells score, or in addition to that, or independently from that, by doing the D-dimer test, which has less than 1% of false negative results. The ultrasound by itself has about 4 to 6% false positive rate. So if you do probability of DVT is less than 1% and do ultrasound, you ended up of 4 to 5 patients out of 100 that have false positive results and will be treated. So for those patients to wait until the ultrasound is done without any treatment is a risk. So it's much better to put those patients on anticoagulation right away and then do ultrasound in non-urgent manner, but within, as the guidelines recommend, within 24, 48 hours. The ultrasound part of this is also interesting because the longer you wait from the onset of symptoms, the more reliable is ultrasound. Fresh clots are very difficult to see on ultrasound. Sometimes they look like a normal vein. The more mature clots are much easier to identify. So by putting the D-dimer and the clinical score first, and then acting upon those things, you actually much improving patient care.
Sure, I'm Dr. Dave Knierim, and I am a family practice physician by trade. I've been in ProMedica for about 10 years. Recently, over the past few months, I've taken on the role of medical director for our urgent cares to try to help improve our education and provider support, and also standardize care across the system. We want to give our patients an easy way to access the appropriate level of care. And I think for DVTs specifically, this is a condition where patients come in with unilateral leg pain and swelling. Historically, that'd be an automatic referral to the ED, where they would end up with a weight and eventually a bigger bill than they might possibly need. So I think looking to improve the appropriateness of those patients and try to keep some of those patients at the urgent cares instead of sending them automatically to the ED, I think would be a huge victory.
Sure. Dr. Brian Kaminsky. I'm an emergency department physician. I'm medical director of the emergency department at Flower Hospital, and I also have a role with ProMedica, and I'm vice president of quality and safety for the system. People present in a variety of locations with concern that they might have a blood clot in their leg or DVT, and sometimes they just present with swelling and pain, and they don't know what it might be, and then we investigate and try to determine whether they do or don't have a blood clot. Mostly it's the former, so people who develop leg pain and swelling might talk to first a family member, then maybe a neighbor, and then somebody else they know, and eventually somebody says, well, you might have a blood clot, you better go get checked and make sure that you don't. And tell that person at that point in time that you need a Doppler or an ultrasound of your leg. And while sometimes we do that, that actually isn't our standard practice. When patients come in to seek care with a moderate or mild suspicion for DVT, often the first thing that we do is blood work, because we can often determine that they do not have a blood clot. In most cases, just doing a D-dimer study. Even though DVT is potentially a life-threatening condition, can be very serious, the number of people that we see that suspect they might have a DVT is much higher than the percentage that actually do. So we do a lot more evaluations and workups for people that are either concerned or have some of the signs and symptoms of a blood clot, but it's actually something much more benign, either a muscle strain or Baker's cyst or some other musculoskeletal problem, or just mild insufficiency of the veins of the leg that cause some swelling. So we do a lot more investigating for blood clot than we do finding blood clot. And that does tie directly into patients that come into the emergency department from the urgent care centers, because a lot of the time they might show up expecting that we're going to do a study right away, and that actually isn't the most sensitive study that we have. And even see sometimes in some urgent cares, they come in having been told that that's what we're going to do. And although that is one tool that we use, it is not a tool that's available 24/7. It's important to have pathways that allow us to treat patients effectively and safely without having that resource available at all times. And we believe that we're able to do that in the majority of cases. And in most cases, we don't need to do a Doppler study. We're able to do it with a physical exam by using certain criteria on a physical exam, and then also combining that with laboratory evaluation that is available 24, that in most cases is able to put people into a category either very low risk or persistent risk, and those with very low risk are able to go home, and we're able to assure them that it's not likely to be a DVT, and those who still remain with risk, then we can provide the appropriate follow-up for them to receive additional diagnostics, whether it be an ultrasound or repeat evaluation, in order to determine if there is an ongoing concern for a blood clot. Yeah, the well score is a great tool because it doesn't cost anything. It's not invasive. It doesn't harm anybody. It's a tool that we use just based on historical information and physical exams. So you can conduct a well score by just walking into the room, examining somebody, and asking some questions about their past medical history. And at the end of that, you can actually place them in a category. The Wells score itself is a fairly good tool. It isn't bulletproof. There are some limitations to it. It can't capture every single person that has a blood clot and those that don't. So it does have its own inherent false negative, false positive rate. But what we found is that when we combine that tool with a laboratory study, the D-dimer, it has an extremely high negative predictive value. A negative Wells score in combination with a negative D-dimer tells us with the greatest certainty, better than any other modality out there. In fact, anything that's one or less, we would consider to be a low risk or negative study. Yeah, there's a lot of things that cause swelling, and it's important, I guess, first to probably talk about whether or not it's unilateral or swelling in one leg or swelling in both legs, because it's really, really rare for somebody to present with bilateral lower extremity swelling and that to be representative of bilateral DVTs. That's just something that we don't see commonly at all. So most of the time when people get a blood clot, they only get it on one side. So by far and away, those people who are worried about a blood clot and they have equal and symmetrical swelling of both legs, it's more than likely something else. So it's something else like venous insufficiency, which is a condition where the veins don't return circulation back to the heart as quickly as they should. Sometimes it's just a little bit of fluid overload or water retention. In females, we sometimes see related to menstrual cycle, right around the menstrual cycle time, women will retain more fluid, and that's usually equal and symmetrical. And then there are more serious conditions like heart failure that can produce that equal and symmetrical swelling of both legs. When we see it on one side, there again are a variety of things. Sometimes circulation in the veins is just better on one side than it is on the other. We'll often see it in cases where people actually strain a muscle or pull, a calf muscle that creates pain and sometimes swelling. And then a Baker's cyst is it's an accumulation of fluid from the knee joint behind the knee. It's a very common condition. It can occur acutely or it can be a chronic thing due to chronic inflammation of the knee. And that can cause pain and swelling that can mimic signs and symptoms of the DVT. Sometimes body habitus, obesity can make people more predisposed to develop swelling or lymphedema of the lower extremities. And then other inflammatory conditions, certain joint conditions, arthritis, can cause swelling, gout, and osteoarthritis, rheumatoid arthritis. Those things can also cause pain and swelling on one side that can mimic the signs of a DVT. in most cases, people that develop a blood clot in the leg, we can treat them effectively as an outpatient. So this is an outpatient illness that's treated with blood thinner. So most blood clots that exist below the knee are relatively benign. In the old days, we actually didn't anticoagulate these at all, and they would just get better with time in most cases. We've learned now that a fair number of these propagate and become more extensive, so we do anticoagulate those. And then there's DVTs that extend above the knee but don't go beyond the hip. Those are a little more serious. They can be more symptomatic. And then there's the very extensive DVTs, the ones that we call iliofemoral. They go up above the hip, all the way down the leg, past the knee, and really occupy the entire deep venous space from the iliac vein, which starts in the abdomen and goes all the way down, ultimately into the foot. And if you have a blood clot that extends all the way down, that's more serious. In general, those people need to be admitted to the hospital. They need to be placed on IV blood thinners, and they need to have vascular therapy to alleviate that clot burden. Our D-dimer assay, the cutoff is right around 250, and typically people with those large iliofemoral DVTs have D-dimer scores above 700. Yeah, I think what a lot of people believe, and I think it has to do with the fact that, we use technology, so the ultrasound produces an image, and visual images are pleasing. We like to be able to see what we're doing, but they also have their limits in terms of diagnostic capabilities. And what most people don't realize is that the Wells score combined with the D-dimer is far more sensitive than a Doppler study. So there are national practice guidelines that say that if you have a negative Doppler but persistent signs and symptoms of a DVT, you should have either another modality like the D-dimer and a Wells score, or you should have a test repeated a week or two down the line to make sure that as this condition develops, that it wasn't just missed the first time. ER and urgent care, we get a snapshot of what's going on at the moment in time, and we generally try to rule out the most serious things. We like to start treatment on those things that we are able to identify, and then refer appropriately when referrals are necessary. Yeah, I think if urgent care is able to risk stratify patients, then it can put some evidence behind the decision making, because we've tested this tool and we found that it has been validated across not only our own population, but in other organizations that have used a similar tool. They've been able to effectively identify and manage patients with and without DVT and refer them appropriately. And there's no reason that this can't be done in the urgent care setting. It's all about risk stratification and taking first that patient that comes in with symptoms and a concern that they might have a blood clot, and applying some science to it and saying, you're either in a high risk, medium risk, or low risk category. And those people who are in low risk, which is the majority of patients that we see, are able to effectively send home and discharge to follow up with their primary care physician with reassurance that they don't have a blood clot.
D-dimer is positive, and there is a clinical suspicion. Putting patients on anticoagulation, schedule the test, and then do appropriate care later. And most of the patient is ambulatory patient, will save a lot of time, have better outcomes, and will save money for the healthcare system and for the patient. A Wells score are questions that we have to ask the patient if we do the real good practice. If the Wells score is positive, then D-dimer really plays a key role, because there's splits in two categories. If the Wells score is positive and D-dimer is positive, then you're pretty certain that patient may have a DVT. Now, if you have a positive Wells score and the negative D-dimer, it is still possible that patient have a DVT, although the probability is much less. That ultrasound, in addition to this limitation, is a cost. Of course, it's cheaper than venography or CT scan, but it's still quite expensive treatment. On average in the United States, it costs about $2,000 per scan department, where they will do exactly the same and send the patient home. And it's consuming resources of the healthcare system, emergency department, and the patient's money. If you put the patient on anticoagulation and you know that patient can't receive this anticoagulation then definitely that's a way to go. It has been study after study that show that ambulation for those patients is better choice. It carries the same risk. It's not less risk of pulmonary embolism with ambulation, same risk, but it has much better long-term outcomes. And so three components of the treatment of acute DVT today is anticoagulation, ambulation, and compression therapy. Our vascular service is 24/7. So any time that you have any questions or concerns about the patients, it's just a call away. You call. We always have a vascular surgeon or vascular medicine person on call who will take the care of these patients from that point and determine what needs to be done. Dogs are very effective. Their efficacy is the same or higher than the traditional medications that we used. They are also less risky. So the bleeding rates on dogs are very low. The risk of bleeding on Bexaben was the same as the risk of bleeding on placebo. Initially start on anticoagulation, that's the key. You start patient on anticoagulation.
My name's Paula Martinez. I'm the actual clinical manager for the Jobs Vascular and Vein Care group. We deal with all patients that have artery or vein issues throughout the body. And we instituted a while back, almost a year now, a DVT clinic here in our offices for the patients that had gone to the ER. They didn't have a follow-up process in place. Typically the DVT patients, they wanted us to have them get on medications right away. We sat down as a group and a team with our vascular lab, with our research and education department, with our anti-coag clinics, and came up with a process so that we would end up having a same-day DVT clinic. If a patient presented to the vascular lab with a positive result, they would literally send them directly to us. They call our office. They tell us they're on their way. If they can get a referral from the primary care, they get a referral from the primary care, so we can link that with a referral. If they cannot, we will still see the patients that same day. Typically, our APP clinics are run by an APP. However, we don't always have an APP in the clinic, so sometimes our surgeons and our vascular medicine specialists see these same-day appointments as well as needed. The provider will evaluate the patient to determine if they need to be on anticoagulation, and if so, we will provide the patients with samples and prescriptions as needed, and then they also will get a referral to the anti-coag clinic. Our anti-coag clinic deals with the patients both that are on the Eliquis and Xarelto and the Coumadin. So primarily their first visit, they're going to be giving them some education about the medications that are chosen for them. At that same time, we started to looking at trying to do more D-dimer rather than the stat venous scans. And so we are actually, if we have a patient that they suspect a DVT on, we're asking that a stat D-dimer be done prior to them coming to see us. The providers are actually treating the patients based on the D-dimer and their clinical evaluation to determine if they would truly need the venous scan or not. You can call our main number, which is the 419-291-2003. Our call center is open from 8:30 to 4:30. They would take any same-day appointments. If you were able to place the referral for Jobs Vascular, you can choose any provider. If the patient needs a same-day appointment, that provider doesn't happen to be in that office at that time. We do have an after hours, and they would contact our on-call provider. Typically, we like to see those patients either 4 o'clock or before. So I would say a half an hour before close of office is fine for us. Currently, we have 6 APPs. We have 11 surgeons. We have 3 vascular medicine specialists in our group as well. Our main office is here at the Toledo Hospital in the Jobs Towers on the 4th floor. We do run clinics here every day of the week. We also have 17 locations throughout Southwest Michigan and Southeast Michigan and Northwest Ohio. Those clinics are very variable. Some of them, the docs are going to, some of them, the APPs are going to. Every outlying clinic that we have has a vascular lab associated with it as well. So we have made arrangements for any of our patients in those outlying areas that have a positive scan. If our provider is in the office that particular day, we would see that patient in that outlying clinic as well. And our staff will probably ask you where that patient is at so they can determine which location would be most convenient for the patient. That's the process that we set up with the EDs a long time ago because they kind of needed that and set in place. So if that patient needs further follow-up with vascular, we're going to give them an appointment prior to them leaving our office that day. If it's a patient who's not truly a DVT patient, we're going to send a letter to their primary care letting them know what's going on so that the primary care can follow up if there's other issues or concerns. Every system isn't perfect, and the more we work together and collaborate, the easier things are for everybody.